Okay, so I am going to invite Hugh, now Professor of Acupuncture Research at York, and many congratulations to Hugh for managing to get a title out of York at long last, well deserved after all the great work he's done here in the UK in acupuncture. So I'm going to hand straight on just to say that when I do the posters, they're going to be very strictly timed so we can have lunch and listen from the ETCMA. Hugh.
Right. Thank you, Nikki. And this is a great chance for me to present some really exciting new research that's just come out. Well, actually, it's just that it's just been conducted. It's not yet been published, and it's a new analysis of the work that we've done before. Which is the first round of this was published in 2012. The Acupuncture for Chronic Pain. It was an individual patient data meta-analysis, which I'll talk about. And it's had over 500 citations in the last 5 years. No, 2012. What day? Nearly 5 years. So it's a very highly cited paper, and it's got the most definitive data on acupuncture for chronic pain. And so what we've done is we've updated it. That's the content of the talk. And so the 2012 version only took trials up to 2008. So we've had from 2008 to now, to the end of, I think we did to the end of 2015, that would be 7 years. So 7 years worth of more trials. So because the criticism over time is you say, oh, well, you've done that research, but what about all the more recent studies? Do they contradict what your findings are or not? So that's what I'm going to talk about. And so the key questions, and in terms of the placebo debate, this is the most definitive data around, to what extent is acupuncture a placebo? Or the criticism of acupuncture is, oh, maybe it's all placebo. Well, this is the definitive data that I'm going to present on this. The second question is about, is acupuncture clinically effective? In other words, in the real world, if you offer acupuncture, not compared with a placebo, but compared, say, with the usual care, how effective is it? And then I've got some secondary questions, which I've got updates on, is, what aspects of acupuncture are better or worse? How does the choice of control group affect the perceived, how does that affect the size of the acupuncture effect above and beyond the control group? And what about the long-term trajectories? What's this? The data is very interesting on the longer term. So, what this group did was an individual patient data meta-analysis. So, if you do a meta-analysis, you take the summary data from a bunch of trials. If you do an individual patient data meta-analysis, you take all those trials, take all the patients individually into one database, and analyze the data, you get a more powerful analysis of data. You've got more statistical power, you've got, you can standardize, because you've got the individual patients in there, you can standardize more appropriately. We can do better subgroup analyses, but you need to have a collaboration, because when you pool all this data, you have to get the people who did the trials in the first place agree to hand over their data complete and trust you with it. And so we had a great response from the trialists. This is a collaboration team. There's about 30 of us. And all the big trials that have been done in the last 15 years, well, certainly up to the 2008 cutoff, all the big trials, the lead trialists, or a representative of the lead trials, they're all in this list of collaborators. I particularly want to point out Andrew Vickers. He's the key man in all of this. He's the statistician that's driven the whole project. And then there's a few of us that have been part of a writing team and an analysis team as well. So we've worked together to make this study and also for the reanalysis, which I'm going to talk about now. Just to update you on the first time round, we had the same inclusion as we did in the reanalysis. We're looking at chronic pain only. Why chronic pain? Because that's where there's enough data to actually do this analysis. What we want is more studies coming through, so other areas can be analyzed in this way. But at the moment, chronic pain is the area that's been most studied, the most trials, the largest numbers, and the best data set to ask these questions. So we're looking at headache, osteoarthritis, neck and back pain, and shoulder pain. And what we had a single quality criteria. The thing is, if you put low-quality trials into a meta-analysis, people criticize it and say, well, look at all these low-quality trials. We can't trust the judgments, the analysis, because the low quality tends to be more positive. There tends to be more bias in low-quality trials. So if you eliminate all the low-quality trials, that way you eliminate potential criticism that there's a biased sample. And so our single criteria was adequately concealed allocation at the time of randomization. That's been shown to be a key marker of quality. And unfortunately, it meant that we lost a lot of studies because it wasn't clear enough that this quality criteria was met. And we had to have pain as a measure more than 4 weeks after the first acupuncture session as an outcome. So the primary outcome, we took the primary outcome from each trial and said that's the primary outcome, but it had to be at least 4 weeks after the first session. So this is the flow diagram when you do a systematic review or meta-analysis. We screened 1,700 records. This is in the time phase from 2008 to 2015, and we came up with 10 new trials. So here are the 29 trials. That was the original analysis. So now we end up with 39 trials. So it's a bigger data set. The question is, do we get something similar, or do we get some differences coming through? And so the 39 trials had nearly 21,000 patients. So remember our database, we've got, imagine each row is a patient, so we've got 20,800 rows, and we ended up with 6,000 columns. Statisticians would love that. We broke it out into two sets. There were 26 trials with sham controls, and there were 25 trials with non-acupuncture controls. So the reason 26 and 25 don't add up to 39 is because some trials had 3 arms. So they had an acupuncture arm, a sham arm, and a non-acupuncture type control, say usual care or standard care. So we have these 2 questions. These are the 2 primary questions. Is acupuncture better than sham? Politically, this is the most important question because it's about proof of principle. But actually, clinically, the important question is the second one. Is acupuncture better than standard care? That's the question that the GP can ask. Should I refer someone to an acupuncture practitioner or not? The answer comes from question 2. That's the clinically relevant question. The first one is the proof of principle question. So starting with the first question, is acupuncture better than sham? The big challenge with systematic reviews is you lump together all the trials that fit your criteria, and you end up with a smorgasbord of different styles of acupuncture. So we just have to accept, put on hold the fact that actually we think some acupuncture might be better than others, and not all the trials have got the greatest acupuncture from our perspective. But let's just take the acupuncture as it is, pull it all together, and then also pull all the sham acupuncture. So we've got non-needle shams, like an inactive TENS machine that flashes lights that is one option, or the needle-based shams. We have penetrating or non-penetrating, and those needles might be either at acupuncture points or at non-acupuncture points. So in the first instance, we do the lumping again. We lump all those together and say, we don't know if those sham are better or worse than each other. Let's just see what happens when we lump them together. Basically, people who do systematic reviews are either lumpers or splitters. Cochrane people love the splitting, and you end up with, you slice it so finely that you find it difficult to have enough power to get answers. If you're a lumper, you get more power, but you're doing all this averaging across a range of oops. Woo! I'm getting carried away. Anyway, so when you do an analysis, a meta-analysis, you get a forest plot. Who definitely knows how to interpret a forest plot? Yeah, 10 or 15 people, that's great. Can you bear with me while I just explain to everybody else how a forest plot works? Anytime when you look at the literature and you see a systematic review that has a meta-analysis, you should see a forest plot. Okay, so it's in a picture, you get an analysis of, in a single picture, you get a full analysis of what's going on. And so down the left-hand side, these are the lead author of the trials. This is the date of the trial. So here, there's only one trial, it's 2012, that's added to this analysis. Okay, and this is the number of patients, which also relates to the weighting, which is the percentage right on the far side. And here, you've got a zero line running up the middle, and that's the line of no effect, if you like. So if the point estimates, which are the dots here, land on this line, as it does pretty much for the Klaus Linder's headache trial, the migraine trial, it's saying basically this trial, if the point estimate's on that line, there's no effect. But there's a spread. There's a horizontal line, which is your confidence intervals. So statistically significant trials are ones that only, the whole line is on that right-hand side. Like, for instance, the NRIS trial is all on the right-hand side, so that's statistically significant. And that gives the effect size as 0.24. I'm going to come to effect sizes in a minute. But the point is, we've got two trials that cross over the center line, and 1, 2, 3 trials that are what we call positive trials. Then, at the bottom, we've got the combined effect. Okay, this is the important bit. The question is, when you combine these, do you have, and you have diamonds here instead of lines, do these diamonds cross the center line? This is the line of no effect, and they don't. So this is statistically significant, okay, with an effect size of 0.16. That's a small effect, but it is it's, in terms of proof that acupuncture is more than a placebo, this is very strong evidence for headache and migraine. So does that make sense? Does the forest plot, I don't want to go through every forest plot in detail, but just going on to the next one, osteoarthritis. There's a lot more trials, and you can see these are the trial names you can recognize. So we've got 1, 2, 3, 4 trials, 4 new trials that have been added to the ones that came before 2008 or before. And Mavromatis's trial is such a positive trial, it's off the scale there, as is the VAST trial up at the top as well. So they're very, very positive trials. So positive, and I'll come to this, that if you have an outlier that's so unexpectedly positive, you might say, well, let's just say that's an outlier. We might exclude that. Because what you want is a solid set of solid evidence that people can trust. You don't want people to turn around and say, oh, well, there's clearly some bias in this case. So the 4 trials that were added, by the time you put it all together, again, there's a significant effect. This diamond does not cross the fixed effects, which is 0.24, doesn't cross the line of no effect. So again, for osteoarthritis, there's very strong evidence that acupuncture is more than a placebo, but the effect size is small. And then here we've got the musculoskeletal pain. I won't go into too much detail on this, but you can see most of with the exception of Cherkin's trial, which is has on the left-hand side, all the point estimates are on the right, and the diamonds are clearly on the right. So they're, again, definitive evidence for musculoskeletal pain. And this is for back and neck pain in particular, where that acupuncture is significantly better than sham acupuncture. And then what's new for this analysis is the shoulder pain, which is interesting because you can see we had 2 trials before that were earlier than 2008 and before. I'm I'm not quite sure. Anyway, we've got one additional trial here. I'm not quite sure why we didn't have the shoulder pain in the analysis the first time around, but it's a much stronger effect with shoulder pain. We've got 0.57 as an effect size from the diamonds at the bottom. We did have it in. Okay, we had it in, but I've forgotten about it. So what we did in the first study was we excluded the VAST trials because they were the very, very positive trials. And we've done the same again this time. But here we're looking at these effect sizes, 0.16, 0.18, 0.19 for the first three, and then the shoulder pain is 0.58, which is, we don't understand why the shoulder pain should be so much better, but that's what the data says. In terms of effect sizes, just to interpret, 0.8, if you get 0.8, that's a very large effect. 0.5 is what's called a moderate effect. You'd be very happy to get 0.5. And 0.3 or below is considered a small effect. And you can see we've got effect sizes of around about, if you average that, it would be around about a 0.2 as an effect. So that's a small effect size. That has really big implications, which I'm going to talk about in a minute or two. But before I do that, I want to talk about the acupuncture versus the non-acupuncture controls. And here, not only does acupuncture vary, but all the controls that are used in these trials are like no treatment, wait list, attention control, rescue medication, usual care, which sometimes is not very much. In our department, we call usual care benign neglect. Other standard treatment, and that could be quite intensive, sessions of physiotherapy or whatever. Anyway, we do the same thing. Our starting point is lumping. I'm going to show you some splitting later on, but lumping for now. And so here we've got more forest plots. So we're adding a couple of trials. One trial. It's interesting, isn't it? All these trials that came in the mid-2000s. And actually, the number of trials more recently, we had less big trials coming through in the last 5 or 10 years. So only one trial, the Dina trial, crosses the center line. And you can see the effect is quite a lot larger with these diamonds. 0.44 is bigger than we were getting before for headache and migraine. And then osteoarthritis. Again, we've got a few new trials here. 1, 2, 3, 4 new trials. It's interesting. It's interesting because, again, apart from the Foster trial, all the trials are positive. The overall effect's about 0.63, so that's quite a strong effect for osteoarthritis. I don't know if anyone followed the story about in JAMA, the Hinman trial. Was a very its point estimate is pretty much on this red line, which is the overall effect. So that's when it's compared to usual care. The thing is, it didn't show a benefit beyond sham, so that was why it was designated a negative trial. And then musculoskeletal pain. So we've got 3 more trials added in, but the effect is all the trials are positive in terms of point estimates, and the overall effect is 0.54 from the diamond at the bottom. So that's very much what we were getting before. And then if you look at the averages, then remember how I said this was about 0.2 up here? If you look at the averages for here, it's around about 0.5. In other words, when acupuncture is up against non-acupuncture controls, in other words, that don't involve sham, it performs much better. As we said, the effect size of 0.5 is a moderate effect. In fact, it's the effect size that NICE looks for, say with osteoarthritis, it looked for an effect size of 0.5, which acupuncture achieves a 0.5 effect when compared to usual care or standard care. So just to summarize then, we've got the 0.5 effect size when we look at acupuncture for chronic pain. That's our clinically relevant effect size. So if you're practicing evidence-based, if you're practicing using acupuncture for chronic pain, it's evidence-based because it's got the moderate effect size, it's clinically relevant in terms of size, and it's statistically significant. But acupuncture outperforms sham acupuncture with only an effect size of 0.2. Okay, so 0.2 doesn't reach that threshold of 0.5 that NICE were looking for. Interestingly, NICE were only looking for this threshold for acupuncture. The other interventions were like manual therapy and so forth, weren't expected to reach that threshold with sham acupuncture, mainly because they either didn't have a sham acupuncture arm, or if they did, they ignored the effects. So what happens if we've got 0.5 and 0.2? What's the difference? The difference is 0.3. That's how much sham acupuncture outperforms usual care. So sham acupuncture is very good as an intervention. And there's reasons for that. We think it's therapeutically quite active. It triggers all sorts of physiological responses that are engaged with self-healing and so forth. And it makes sham acupuncture trials really problematic because it reduces the apparent effect of acupuncture. I won't go on any more about placebo physiology, but I think that's part of the issue. Just to put this graphically, if you think of, we've got an effect size of 0.5, and we know 0.3 is what sham acupuncture outperforms usual care, then you get 0.2. You get this much extra when you use real acupuncture. So sham acupuncture also includes the context. You know, you're going to a nice warm room with a warm, fuzzy practitioner and telling your awful stories, and you come out feeling bad. You come out feeling better anyway if you have a good therapeutic relationship. So that's all included in the 0.3. That's the easy bit to get. To get this extra 40%, which is what the difference is between, if there's 60% here, you get an extra 40% benefit you wouldn't otherwise get by using true acupuncture. So anyone who says, oh, well, the benefit is too small to be worth having, well, actually, I don't think patients would agree with that. This is exactly what David Cahoon said. He said, it hardly matters whether it's correct that acupuncture is better than sham. So he's sort of implicitly agreeing, okay, and it's based on this paper, okay, acupuncture outperforms sham, he says. But what really matters is that Vickers et al. Showed that the difference is far too small to be of the slightest clinical interest. So that was the only criticism we had of our paper in the academic and medical press. You know what? Right. So I'll keep going. So that's an interesting point. You know, this is a very small effect. That was the criticism. But if you look, this takes osteoarthritis. This is a paper that Stephen Birch and colleagues, I think Mark's been involved in that as well. They looked at all the effect sizes of different drugs against placebo, okay? That seems a fair comparison because things like paracetamol or NSAIDs, like ibuprofen and the COX-2 inhibitors and so forth, they're regularly used for the treatment for chronic pain. But what's the effect size they have against the placebo? Well, paracetamol, there's two studies here. You can get, by the way, you can get from the journal, the Blue Journal, the JACM journal, this whole paper with references. But they quote two studies, one where the effect size is 0.14, and the other where the effect size is 0.21. That's the same ballpark, okay? NSAID's 0.29 and 0.37. It's a little bit bigger. It definitely doesn't reach the 0.5 that NICE is looking for. So NICE quite very conveniently overlooked that fact. COX-2 inhibitors slightly better, topical NSAIDs again. But notice the only one that reaches 0.5 are opiates. Imagine, and you can't have opiates as your first line treatment for chronic pain, can you? But if NICE was fair in treating all interventions equally, they would knock out all of these drugs except opiates. Or, much better, they'd change this assumption that the comparison with placebo has to reach 0.5. Acupuncture is never going to get to 0.5. Okay? It will for usual care, but not for comparison against placebo. So, just another criticism, potential criticism. We never actually received this one because we said, look, because the people say, oh, well, it's probably in the filing cabinets of researchers, all the negative trials are just put there because they don't want the results to be published. That's the story. But you'd need 50 trials, this is the sham controls, or 100 trials in the case of no acupuncture controls, with a standard deviation of 0.25. That's quite an effect size to change the results to be non-significant. This is the chances of this are just totally ridiculous. Of there to be filing cabinets with 50 or 100 trials dotted around the world sitting there, all negative. That doesn't make sense. So anyway, no one's criticized this on publication bias because of this data. And then just to keep going with the story, and this is, so I'm going to give you mostly updated data on this. What aspects of acupuncture are better or worse? You know, we all have our own special style of acupuncture that we think is great. That's why we practice it. We don't practice other people's styles because we don't think they're as good. And we thought, well, it'd be good to have a look and see, you know, does TCM style do better than Western medical styles of acupuncture, and so forth? Does individualized points outperform formula or flexible formula where you have some fixed points and some flexible ones? All of these questions are part of this first one. And what about control group? We talked earlier about different styles of sham, for instance. And what about the longer-term outcomes? Which I think this is, I haven't really taken on how important this is, but I'll talk a bit about that too. So we've published on the first set of data, already published the full story of acupuncture characteristics. This is the updated data. It says we find exactly the same results. We find no significant variation in the sham trials related to the style of acupuncture or the characteristics of the acupuncturist or whether the De Qi was achieved or not or obtained or not. You know, there's a whole bunch of detailed questions about the styles of acupuncture. Lots and lots of questions we asked. And I think basically acupuncture is a very complex intervention, involves multiple components, and there aren't any individual components that stand out across all of the components we looked at. But when we looked at acupuncture versus non-acupuncture, we found that more sessions were better. And I think most acupuncturists would agree with that, less sessions is not as good as more sessions. You sometimes think that might be self-interest on the part of the practitioner. More sessions is more business. But I think most of us would say, well, actually, we do get better results. But it only went up, I think 15 sessions was the longest of any of the trials here. So we're not talking about the very long-term treatments that sometimes patients are involved in. Study 2, what about the different controls? So this is important because, when you interpret a trial, have a look at the control group, and that will help you understand the trial. We published this based on the original data, and I've got updated data on this. So we looked at the usual care, and we split it into two. If you have a high-intensity usual care or control group, high intensity might be, say, Nadine Foster's trial in Kiel. They had 6 sessions of physiotherapy in the control group. Okay, so that's quite intensive. That's one of those trials. And we compared with the usual care or low intensity, which were everything from waitlist to benign neglect and so forth. And so you can see the acupuncture's effect is coming in about 0.5 for these 19 trials, but it comes in with acupuncture when compared to low intensity, it's more about 0.3. Okay, so if you have very intensive control, which is therapeutically active, acupuncture won't outperform that control as much as if you have a low intensity control. Does that make sense? Yeah. So this is the updated data, and then we also looked at penetrating versus non-penetrating sham. Almost all the trials with penetrating needles were not at acupuncture points. Almost all the non-penetrating sham were at acupuncture points, but not penetrating the skin. And interestingly, we've got two fairly equal groups. There's 11 and 10 trials in these two groups. And this is a dramatic result. We didn't expect anything like this, in that if you're comparing with penetrating needles, acupuncture doesn't perform very well when compared with penetrating needles. Physiologically, penetrating needles are very physiologically active by the look of it, with effect sizes of around about nearer towards 0.2, whereas when you compare acupuncture to non-penetrating sham, across all these trials, hey, it's 0.5. Remember I said about 0.5 is what NICE looks for. So if you have the better the sham control, the less therapeutically active it should be. And clearly, non-penetrating sham is a better control if you are going to do sham-controlled treatments. I don't know if NICE could be convinced that they should be looking at this type of sham and not this type of sham. That remains to be seen when next they look at osteoarthritis, for instance. Will be interesting to debate that one. So, just to summarize, acupuncture is significantly superior to all types of control. It performs less well against a high-intensity control group when it's non-acupuncture control. And if you want to use a sham needle, probably better use a non-penetrating sham needle because it elicits less healing response than the penetrating needles at the wrong points. And then the last of the sub-studies, the outcome trajectory at 1 year. Now this paper has been published online, but it's coming out in print in May. That's in just over a month. And so I'm going to present, I'm only going to give you the headline figure. When you compare acupuncture to sham, at the 1 year after the treatment, only 25% of the benefit is lost. In other words, 75% of the benefit is sustained. Whereas when you compare acupuncture to non-acupuncture control, only 15% is lost. Actually, when we did it the first time, this was 10%, so this has gone up to 15 in the new analysis. But this one, 25%, is reduced from 50% down to 25%. So quite a little bit of a shift there. But this is really important because we talked about drugs earlier. They tend to have short-term effects, don't they? For these courses of treatment, to sustain the benefit on average, sustain 85% of the benefit is actually, I think, quite a remarkable finding. And it's really important for cost-effectiveness analysis because when you do the cost-effectiveness analysis, you look at the trajectory of change, and you could say, all right, this is the expected trajectory. The set cost savings over the longer period of time can be factored in, along with the clinical benefit that's sustained, to give you better cost-effectiveness data. In other words, if your benefit is sustained twice as long, you'll have twice as good cost-effectiveness. So this paper, if anyone wants a copy of the new paper, they can always email me. But it's, in terms of taking evidence out there, it's a very strong story. So just to continue, so what was good about this study was the individual patient data and meta-analysis aspect, the fact that it's statistically more powerful, that we only used high-quality trials reduces criticism. We had large patient numbers, and we've got, we think, the most definitive results on the placebo. So anyone who says, what about the placebo? This is the paper to quote. And that's not just because I want more citations for the original paper. However, as always, you're limited by the available studies. We had lots of the big stud trials were done in Germany. That was a particular context for many of the trials. Almost all the trials had weekly sessions, whereas in China, treatment is like five sessions a week perhaps, or a course is 10 sessions over 2 weeks. None of the Chinese trials, when we looked at them, actually met our quality criteria. And we would like more trials. Our subgroup analysis, by the time we did all the splitting up in this, so when you split things out, you lose statistical power. And the more splitting you do, the less confident you can be about any differences. We would like more trials, so that would add to the database. And hopefully the collaboration is keeping going. Hopefully we'll have another round in another 5 or 10 years. We can add to this data set. Although I have to say, it's a huge amount of work and it has to be funded because all these trials, when they came into the data set, they were reanalyzed to check that they had valid data. And then there's the big meta-analysis itself. It's been a big job. So what's the conclusion? Acupuncture outperforms sham. So this is the proof of principle, if you like. For chronic pain, at least we know acupuncture is it's more than a sham or a placebo. Statistically significant, similar effect sizes to many of the drugs that are commonly used for chronic pain. And conclusion 2, this is acupuncture is for when compared to non-acupuncture controls, we can say this is the clinically relevant context for a referral from a GP, or when a patient comes in, can we deliver some sort of benefit? We can say we can say when we treat chronic pain, we're practicing evidence-based medicine. There's a moderate effect size of 0.5. 85% of that will be sustained at 12 months. And more acupuncture sessions lead to better outcomes. So just to acknowledge various grants and so forth that helped us on this. And if you get access to this set of slides, by the way, I think you can access it through Mark after the conference. These are the references that have come from the Trialist collaboration. Pretty much all of them are open access, with the exception of the last one, which is currently not become published. Is that right, Mark? We can have the on the website, is it, or somehow? Somehow. Mark will know.
Somehow should be.
Yeah. And then, just if I can give a little bit of a plug for people who might think, I'd like to do some research, but you're based in your local town. It's hard to get to a big city to do studies and so forth. This is an online module-based master's up at the Northern College of Acupuncture. I'm a trustee of the Northern College, just to declare an interest. Actually, I'm chair of the trustees now that I think about it. The idea is it's the one way for people to get into research with support. And if you want to find out more, there's a stand here, and Lara, who's at the back, she'll be on the stand just to have a chat about, because we want more people doing research in the field. We need more research, and so forth. Okay, thank you.
Thank you. Brilliant, Hugh. Thanks so much. We have time for 4 minutes of questions, and I can see Julian, I can see 3 here I can see, and I'm going to bring this because people can hear.
Two quick questions, but anyway, do the first one. So 60% of the total effect of acupuncture for chronic pain is achieved by the sham, we are saying.
But the
by the non-specific.
sham plus the context of the warm room,
Indeed,
the friendly,
that's right.
the friendly practitioner.
Indeed, but we know sham acupuncture is not the same as a placebo pill. So what is the effect size of a placebo pill?
That's what I showed you on the...
You showed the difference between the painkillers and a placebo painkiller.
And in terms of effect sizes.
The effect size of the placebo pill alone. So how different is that to the effect size of sham acupuncture? I was curious.
Yeah, the effect size of a placebo pill is similar to the effect size of sham acupuncture.
Right, okay.
Yeah. Roughly, neither of them reach this 0.5 threshold that NICE look for, unless you're talking about opiates.
Yeah, that's great. I just wondered how similar they were. And just really, really quickly, did you do a result with the outliers?
With what?
With the outlying trials, the VAS and the other one beginning with M that I can't remember.
Yeah, if you add in the VAS outlier trials, you get a more positive effect.
Yeah.
But we thought we want, again, this is about credibility of this. So our decision at the first round was to exclude the VAS trials. The 2 trials were excluded because they were just way off the map. They were too positive that people could criticize them and could then dismiss the whole analysis.
It'd be interesting to know what was different about them, wouldn't it?
Yes, well, we don't know, but it's interesting. But the shoulder trial, the VAS shoulder trial, wasn't extreme. So
I have a question about what is defined as chronic pain in these studies, as far as a patient been in pain for 1 year, 5 years, 10 years, and does that affect the data?
yeah, I can't remember the exact criteria, but I think they had to have been in chronic pain for at least 4 or 6 weeks. The trials all had their own criteria to bring people into their trials. So when we're lumping together, we just have to say, we just have to adopt the final outcome point, the exact criteria for what defines chronic pain. But mostly, pain has to be a self-rated scale, because I can't tell how much pain someone else is in or not. So people use self-rated scales. To get trials published, you need to use validated self-rated scales. So when you use a chronic pain scale, there's different sorts of, like the McGill present pain intensity scale. It's validated in the literature, so we know that's a valid measure of pain. But at least 4 weeks, if I remember rightly, of pain before people will be allowed in the trial.
Just one ever so quick question, I mean ever so quick.
Did you conduct your research on the musculoskeletal pain conditions or any other chronic pain conditions associated with systemic diseases as well?
Again, each trial had its own criteria. So some trials might say, let's exclude systemic pain from, say, rheumatoid arthritis or ankylosing spondylitis, and other trials might not. This is a mixture. But generally, most trials would want to have relatively simple chronic pain and not have a complicated pain, particularly not have, say, cancer-related pain, because we're looking at everyday musculoskeletal problems. So that's, you have to look at the individual trials to answer your question, though.
Thanks so much, Hugh. I'm really sorry to cut it short because I know that there's lots of questions here, but you can catch him at lunchtime, I'm sure. Okay, right. We are going to have... Thank you.